The title of my presentation is Incidence Rates of Difficult-to-Treat Rheumatoid Arthritis in Real-World Clinical Practice. Our hospital is surrounded by rice field. The world's first guideline for the treatment of RA was developed by ACR in 1996. In the part of goals of treating rheumatoid arthritis, following sentence is written: while the ultimate goal of treating RA is to induce a complete remission. This occurs only in rare cases. These days, remission was a dream. However, the situation has changed. In the editorial for ACR recommendation published in 2008, the first sentence is as follows: the treatment of rheumatoid arthritis has changed dramatically in the past decade. The goal of treatment is to achieve and maintain a state of remission, nor, at the very least, a state of low disease activity, in order to prevent joint damage and disability. This graph shows time course of disease activity using DAS28 ESR in our data, which is called Toyohashi RA database TRAD. We have recorded patient characteristics, data of medication, laboratory data, disease activity, and so on yearly. We treated 1,011 RA patients in 2020. Although disease activity of RA patients has improved from 2009 to 2014, improvement of disease activity has stopped after 2015. Similar trend is shown in EULR data of Tokyo Women's Medical University, which is representative cohort in Japan. Although condition of our patient has become improved so much, there seems to be other patients who is in unsatisfactory condition. What kind of other patients are in unsatisfactory condition? What should rheumatologists do for these other patients? Difficult to treat RA was advocated by De Gea et al. In University Medical Center Utrecht. They proposed to use the global term difficult to treat RA, defined as persistency of signs and or symptoms suggestive of inflammatory RA disease activity despite prior treatment with CS DMARDs and at least 2 biological DMARDs. This slide shows the management cycle of complicated, difficult-to-treat RA presented in De Gea's paper. Factors in pink, which influence results, the ideal drug management cycle, and lead to difficulty in grading RL activity or drug effectiveness. All these factors may, in different grades, in individual patients contribute to difficult-to-treat RA. Categorization of individual and successive refractory drug response using biologics was presented in Baha's paper. There are 3 kinds of refractory conditions. intrinsic refractory, pharmacokinetic refractory, and false positive refractory. Persistent inflammation and no anti-drug antibody are features of intrinsic refractory. Persistent inflammation and anti-drug antibody present are features of PK refractory. No persistent inflammation and no anti-drug antibody are features of false positive refractory. EULR definition of difficult-to-treat RA was developed in 2021. This definition comprised three parts. At first, treatment according to EULR recommendation and failure of two or more biologic or target synthetic DMARDs with different mechanism of action after failing conventional synthetic DMARD therapy unless contraindicated. Second, one or more signs of suggestive of active or progressive disease defined by this definition exists. Third, the management of signs and or symptoms is perceived as problematic by the rheumatologist and or the patient. Relationship of difficult-to-treat RA patients and EULR recommendation are shown. RA patient who cannot escape this vicious cycle in phase 3 is D2T-RA patient. Incidence rates of D2T-RA in real-world clinical practice is unknown, so we researched this issue using our clinical data and presented this study in EULR2021 as D2T study. 363 RA patients who fulfilled the following three requirements were included in this study. 1. Patient had been treated with one or more biological or target synthetic DMARDs. 2. 1 or more years had passed since BTS DMARD treatment was initiated. 3. Patients who regularly visited our institute at the time of investigation. Modified EULR criteria was used for definition of D2T-RA in this study. A. 2 or more BT DMARDs with different mechanism of action had been administered. B. At least moderate disease activity, DAS28 ESR is over 3.2 or CDAI is over 10 at the time of investigation. C. 7.5 mg per day of prednisone or more was administered at the time of investigation. In this study, D2T-RA was defined as criteria A plus B or A plus C or A plus B plus C. Included patients were categorized in one of the categories as below by disease activity, laboratory data, and amount of used prednisone at the last observation. Group A includes D2T-RA. Group B includes RA patients who had been treated with 2 or more BTS DMARDs and did not fulfill the D2T-RA definition. Group C includes RA patients who had been treated with one kind of BTS-DMARD with the same mechanism of action. For example, two kinds of tumor necrosis factor inhibitors, and fulfill either or both criteria B and C. Group D includes RA patients who had been treated with one kind of BTS-DMARD with the same mechanism of action. For example, one tumor necrosis factor inhibitors or two interleukin-6 inhibitors, and did not fulfill either or both criteria B and C. This slide shows incidence rate of D2T-RA as a result. D2T-RA patients were 9.4% in RA patients who had treated by one or more B or TS DMARDs. D2T-RA patients were 39.1% in RA patients who had treated by two or more B or TS DMARDs. Orange group were Group B, blue group were Group C, green group were Group D. We also investigated patients' characteristics at the beginning of bio or JAK inhibitors. Statistical comparison analyses were performed between Group A and Group B. Group A, which included D2T-RA, had long RA duration, worse time blocker stage, worse time blocker class, and more concomitant prednisone usage. We also investigated patients' characteristics at the last observation. Statistical comparison analyses were performed between Group A and B. Group A, which included D2T-RA, had long RA duration, worse time blocker class, and more concomitant prednisone usage. Disease activity is different between groups, and MHAC in Group A was worse compared with Group B. In conclusion, D2T-RA occurred in 9.4% of patients treated with B or TS DMARDs. Incidence rate was increased to 39.1% after the treatment with two or more B or TS DMARDs. The patients with D2T-RA tended to be older, have a long RA duration, have progressive joint damage, be worse in activity of daily living, be treated with concomitant prednisone at the time of starting the B or TS DMARD treatment. The baseline patient characteristics in Group C were similar to those in Group A. In the future, we suggest the patient with D2T-RA be included in Group C. Thank you for your attention. My studies and lectures are uploaded in YouTube channel. The name is So That Is the Rheumatology. Please subscribe my YouTube channel. Thank you.